There we go. Is that okay? Can you see that okay?
That looks good.
Okay, thank you. All right, thank you so much, Dr. Drummond. Thanks for having me. Thanks for inviting me. I remember talking to Aaron and Chip a few months ago. We went out to lunch, had a great time. I was excited to be invited to be here. A little bit more of my history. I started being part of the clinical instructor for UCF when I used to work at the VA at Lake Nona way back in 2014, almost 10 years. So I always have a great gratitude for UCF for inviting me and bringing me part of the family for UCF, and also teaching medical students. They're so smart. It keeps me young, which I love. I like the way they teach the education there, and they always update me on new information to how they teach the medical students. It's phenomenal. But anyway, I'm here to talk about plastic surgery. That's what I do on a daily basis. I also do not only cosmetic, but skin cancer reconstruction and breast reconstruction as well. But the idea that Aaron and Chip brought forth was what can I talk about plastic surgery? Everybody knows about plastic surgery. They see it on TV all the time. And I have a different thought about it just over the years of my experience of dealing with plastic surgery, and how plastic surgery and social media are merging, and how patients see plastic surgery through social media, kind of a filtered approach to reality. So I always was interested in that. So I'm going to talk about that today. So I have no disclosures. So what is beauty? So that's the ultimate goal of understanding what plastic surgery is about. We have an idea of what beauty is, but I always thought about what's the first thing that we do when we're babies. And the idea is that babies analyze faces all the time. When they're first born, who do they see first? They see the mother, the father, they see grandparents, and their visual field, their visual depth is not that far. It's only like a foot in depth. So they're constantly analyzing their mother. They're constantly analyzing their father and their grandparents. So they recognize familiar faces. And so as they get older, babies' visual field gets a little bit further. And so that's when you see, when you're down at MCO airport, the visitors, the tourists come, and you're riding at the train to go to the terminal. You see all these little kids that are going to Disney World staring at you, because they're looking at you because you're different. They're used to seeing their parents, but they're also analyzing you in general. And one of the neatest things I remember during residency is they call it eye tracking. So this is one of the early studies where they look at, show a photo to people, and they can track their eyes, how their pupil tracks. And you can see here on the top left, and then the bottom left, there's somebody watching that image or looking at that image, and they constantly back and forth along the eyes and the nose and the mouth, and it kind of creates a T. And then the visual periphery is less noted. Same thing on the top right and bottom left, it demonstrates a T. These are the early studies of eye tracking. So that's how people analyze each other. When they meet each other, you make eye contact, and you're just doing this automatically, because over the years and decades of growth since you're a baby, you're looking at individuals like this. And then this is a modern version of that. This is called a heat map. So you can see if you think of the red is hotter areas, more visual eye contact, looking at the patient or the person individually, just analyzing the face, looking for symmetry, looking for ratios, things of that nature. So that's for the face. The body's the same way. Men and women, of course, look at the body parts different, looking for a mate possibly through evolutionary processes, seeing how if that person's a good compatible person. And the idea is like, what makes a person beautiful? What makes an object beautiful? If you go out in nature, you see a tree, a plant, animal, what makes it beautiful? Back in the day, the Greeks believed that there was this golden ratio. Okay, so the ratio of 1.618 to be the most pleasing to the eye. So they try to take something subjective to objective. So you see all the Greek sculptures, a lot of those will probably have incorporated some ratios in there of 1.6, the height and length, the arms and elbows and things like that. So they incorporate that into their buildings. And this is the schematic of the Parthenon. in Greece. You can see here the length here of 1, but 1.6. And if you keep subdividing it, kind of a fractal pattern that's more aesthetically pleasing to the eye. Another part of the golden ratio here, again, there's the image of the Parthenon. You subdivide it, everything goes down to 1.6 ratios. The violin, my great-grandfather from Basel, Switzerland used to make violins. So I think his violins are beautiful. So it probably has to do with the golden ratio. Mona Lisa, sunflower. These are all golden ratios. And this is kind of the unconscious way that humans look at beauty. It's kind of a ratio. Everything likes to be symmetrical. People like things symmetrical. And so how does this translate to looking at plastic surgery? How do we look at somebody and say, that person's beautiful? So again, this is schematic, very basic, but it gives an idea that when you analyze somebody's face, you're unconsciously kind of looking for those symmetries. You're looking for asymmetries. You're looking for proportions, one side versus the left side. You can see here in the middle image here, we're looking at the ratio of the bottom third of the face to the top third of the face. That comes down to 1.68. And then also the width of your face. If you split your face in half here, we're looking at ratios to the left and the right. So our whole body is constantly analyzing on an unconscious, subconscious level of beauty. Here's a diagram or basically a digital reconstruction of all the ideal ratios. You can see here, everything's all point out to 1/3, 2/3. This is a very common ratios and plastic surgery. We're trying to make things symmetrical and try to make things more improved ratio. Okay, so the closer you get to the golden ratio, 1.6, with these symmetries and the ratios, then apparently that's what human beings like. And so if you look at a supermodel here, they kind of did a little quick analysis here with these percentages. How close are you to the golden ratios? A certain percentage, a higher number, the closer you are. Supermodels are supermodels because of these ratios that look for beauty. So it'd be interesting if I did one. I wonder how close I'd be to 94%. Probably not, probably really far off. So then you have the K-pop stars. Okay, they're very popular, handsome young men. So again, there's your ratios with the K-pop stars and men. Okay, so with plastic surgery, how do we take these ratios? Well, there's a lot of smart people in the history of plastic surgery, not only for reconstruction after World War I and World War II to reconstruct wounded soldiers, but also over time, how to reconstruct somebody that has good dimensions to make them look more human again after a significant trauma to their face or body. So plastic surgery in general, as I see it, is a mechanism to improve facial and body aesthetics, surgically improve the face and body ratios. Also, there's been studies that showed improves mental outlook on patients. You know, if somebody has a disfigured face like rhinophyma, which is enlarged nose, you can easily fix that to bring them back to normal ratios so they feel better about themselves, reduce phobias in society. Also, with plastic surgery, we strive to improve the confidence of patients. And also, it's shown to show improved life satisfaction of patients. So the main goal is to try to bring the patient back to wholeness and bring them closer to those golden ratios. Again, here we have things for rhinoplasty here. This is just basically just a digital image. You know, we have ratios that we look at that has been studied in plastic surgery. You know, an ideal nose is 1/3 the length of the face and the nasal tip, and the ratio is 1/3, 2/3. You have these angles that are all proportional. So all these have been kind of fleshed out, if you will, to show what looks good and how do we get to that. And the plastic surgeons over time in the decades have developed certain surgical techniques to get us there. Again, here's the face, another idea of, the eyelids, eyebrows. The more useful look is the positive canthal tilt. So you have, if you draw a line from the medial canthus here to the lateral part, it has a positive canthal tilt. That's a more youthful look. As we age, everything, that arrow kind of droops down. So, you know, eyebrow artists these days, they try to recreate this ratio here. to have a more youthful look. Artists over time, if you look, the great artists of the Renaissance and thereafter, they have demonstrated, improved upon. You can easily look at a photo, or I'm sorry, you can look at an oil painting and know right away if that person's youthful or not youthful, based on these symmetries in the golden ratio and the positive canthal tilt and the eyebrow arch and other parameters that we see. So, as I mentioned just previously, with plastic surgery and mental health, multiple studies have demonstrated cosmetics improve overall mental well-being, reduce their social anxiety, reduce body dysmorphia, the lower and decrease in reduced depression about themselves. They feel more confident about themselves and reduce social phobias. This simple surgeries, simple cosmetic procedures, even with reconstructive procedures, those are huge psychological improvements that boost the patient. So with social media, so dovetailing social media, how we look at people, the golden ratio, social media has been a huge influence on plastic surgery. Plastic surgery is a very visual field. Social media has definitely helped my business and also other plastic surgery private practitioners around the globe. But there's a certain parameter that we have to have, certain guidelines. And the Plastic Surgery, American Society of Plastic Surgery, and American Board of Plastic Surgery sets those guidelines to make sure the patient has certain autonomy, respect of the patient, all the things we learned in medical school with medical ethics. So these two societies do a great job, very progressive, keeping ahead of the curve with these new technologies that are on the market to protect the patient, protect plastic surgeons, and also protect the patient against expectations. One of the things in plastic surgery is reaching a patient's expectations. A lot of times these patients will come in with, they use filters quite a bit. Almost everybody on social media now uses a filter. The filters have gotten so much better than the cartoon cat and the lions that were first used on the iPhone probably about 4 or 5 years ago. Almost indistinguishable. Everybody looks so beautiful online using these filters. So as a plastic surgeon, you have a patient that uses a filter all the time, but then bring that filtered image to you and want to recreate that filtered image to reality. So how do you deal with a patient that uses filters all the time that want to recreate this filtered look, but they're not even close to looking like that filtered image? So that's the chiasm you have to relate to patients with social media. Certain expectations cannot be met with these patients. So my thought when I was talking to Aaron and Chip about this is social media augments reality. And I think it absolutely is, because anybody can be anything on social media. But when you meet them on person to person, there is no augmentation, there's no filters. And then looking at cosmetic plastic surgery, I think that's also augments reality. Patients have a nasal deformity, facial issues, things like that. Plastic surgery can augment the reality of that person. So what I mean by augmented reality, classic, or not a classic movie, but a more recent movie, Free Guy, demonstrates this, where it's basically a guy living in a computer game, and he puts these special glasses on and he sees reality. Everything's augmented, so everything's enhanced. So that's what I talk about, the filters with today's society. And then here's another image that I'm talking about, augmented reality. This is actually a reel that I was searching through. This is so fun. You go on Instagram, you can go out down the rabbit hole. These special Instagram reels where young women and men will put on a filter, and then they'll slide themselves over or stop the filter to see what the filter looks like with on, and then the filter off. You can clearly see the one on the left is filtered, and then this one is unfiltered. But you can tell right away. But using your scanning ability that you learned when you're an infant, she has all the features of more aesthetic look, the positive canthal tilt, higher cheekbones, the straighter nose, the straight jawline compared to this. Although she's beautiful in both images, this enhanced photo is what she puts out to the real world. So how do you deal with somebody that comes in like this? She comes in like this, looking like this in person, but then wants to be like that. So how do you deal with that? And again, you're scanning the face or the image just like I showed before, all automatic. And you can tell in milliseconds which one is more attractive. And then as augmented reality, again, is plastic surgery, augmented reality. So Dr. Plank, how do you bring somebody from the metaverse social media world to the terrestrial Earth reality? Okay, they have these filters, and how do you break it to them? How do you say, you know, that's a filter? How do you not hurt their feelings? And how do you bring them to an understanding and expectation for surgery? Well, what I do is I do a simple a test. I have them hold a mirror, and I have them look in the mirror, and I ask them what certain things they don't like. You know, it could be face or body, but there's no filter here. You know, and so then from right there, I can use my techniques and experience telling what's available and what's not available for the patient, what's reality, what's not reality. A lot of times it's kind of hurtful when I tell them the reality to the younger patients. The older patients that don't use the filters a whole lot, they're more understanding. But another technique we use is called the Vectra 3D imaging. Okay, so this is a very valuable tool that I use in my office. It has 6 cameras, all dedicated to triangulate and take an image of the person, their face or body. And it recreates a 3-dimensional image of the person. So you can look at what the patient looks like before, and you can also simulate using software to see what they look like after, before we even do the surgery. So it creates an instant expectation with reality, what you can do for the patient. And actually, it has been a phenomenal investment for me in helping patients understanding what's reality, because it's their face, their body. They can look all they want, all the pre and post photos that I give for patients. But this is so individualized, they love it. Okay. So here's an example. The one on the left here is a pre-photo. The one in the middle is a simulated photo, what they look like after surgery. And then the one on the far right image demonstrates what they look like after surgery. So you can see, you know, clinically, she has a dorsal hump here. The middle photo demonstrates reduction of that simulated version. And then the far right demonstrates an image after surgery. It looks a little pixelated, but that's the 3-dimensional reconstruction. Can't get the eyeballs quite correct. It looks a little fake. So then you can also use Vectra imaging for volumizing for the face, for individuals. How do we get back to those golden ratios? You can use the imaging on here. This is another kind of a heat map for volumizing what's needed, what's lost. So, and also plastic surgery, not only do we surgery, we also do fillers and Botox. Fillers are a great way to bring this back to more of a golden ratio for the patient. And so we use fillers. This is Radiance, newer on the market. So we use fillers to fill that. Here's an example of that before and after. So you can improve cheekbones, improve jawline. Definitely better. You can see aesthetically she's improved just by unconsciously looking at her, just by looking at the ratios that we have done for decades. So overall in plastic surgery, that's what we do now for managing social media, managing expectations of the patient. It's a great vehicle to use, the Vectra, and also a classic mirror. And so social media is a great way, but it is a double-edged sword. So in summary, social media is a great way for plastic surgery to promote health and beauty for the patient. Social media filters grant augmented reality, posing risk for the patient's expectations. But those patients certainly will understand once they see the imaging from the Vectra. And then understanding that filtered results may not be possible for that individual person. And then the main thing for plastic surgery in my practice and all other plastic surgery practices is meeting expectations. So that's all I have. Thank you again for the time. And I guess we'll take questions later.
Perfect. Thank you. Thank you very much, Dr. Plank. We're now going to transition to Dr. Mark Ruffalo. Dr. Ruffalo, are you ready?
Yes, I am. I'm going to go
Perfect. Thank you.
over here. get my slides up. Okay, Dr. Plank, that was awesome. I learned quite a bit. I used to think that there was nothing more different from what I do for a living than plastic surgery, but I think I've come to the conclusion that there's a lot of overlap in our work in terms of helping people feel a bit better about themselves and their lives. So thank you, Dr. German, and to the organizers of this event. I've been looking forward to this for a while. The title of my talk is Psychotherapy for Schizophrenia, an Underutilized Treatment. I'm on the faculty here in the psychiatry residency at UCF, and I also teach in the psychiatry residency program at Tufts Medical Center, where I teach the history of psychiatry and do psychotherapy supervision of the residents. A college student is brought to the psychiatric emergency room due to bizarre behavior, disorganized thinking, and extreme emotional distress. His college roommate notified the dorm supervisor that he had been acting oddly over the past few weeks, talking to himself at all hours of the night and expressing a fear that his electronic devices have been tapped. Upon evaluation, the patient states that the CIA has implanted a radioactive thought monitoring device in his brain and that federal agents have been following him around for weeks. He has considered digging out the device with a kitchen knife and feels that there are spies right now waiting for him outside of his hospital room. He asks the examiner if he too is a government agent. While this may sound like a scene out of a movie, it is the reality in emergency rooms and outpatient offices around the world on a daily basis. I have seen hundreds of such patients. This is schizophrenia, the most complex disease known to man. It afflicts 1 out of every 100 people on Earth. That means that if you graduated high school with 500 people, 5 of them have developed the disease. Unfortunately, there have been no major breakthroughs in the treatment of schizophrenia since the development of the first neuroleptic drugs in the 1950s, the first of which being chlorpromazine or thorazine, a drug still used today. Even with good pharmacological treatment, response is often incomplete, and patients continue to suffer to some degree through the duration of their lives, which are on average 15 to 20 years shorter than those without schizophrenia. What I do is practice psychotherapy with patients with this condition. And I'm going to talk a little bit about the psychological approach to the condition, which I see as being complementary to a pharmacological approach. There's growing evidence that suggests that psychotherapy is an important component of schizophrenia treatment. There are both non-psychodynamic therapies, such as Gerard Hogarty's personal therapy and cognitive enhancement therapy, and Aaron Beck's cognitive therapy and cognitive behavioral therapy, which have been adapted for schizophrenia. There are also psychodynamic therapies, which I practice. My training initially, by the way, is in clinical social work. I'm not a physician, and then I completed psychoanalytic training. Psychodynamic therapies for schizophrenia have a long history. They're mostly anecdotal evidence, but there is resurgent interest in psychodynamic approaches to schizophrenia. As you may know, beginning roughly in the 1980s, psychiatry moved pretty significantly in the biological direction, and many of the psychiatrists practicing today may see schizophrenia patients once a month or once every 3 months for 20 or 30 minutes for medication checks. And few psychiatrists nowadays really practice psychotherapy, and that's especially true for patients with schizophrenia. And I find this to be quite disappointing and a fact that is really, I think, does a disservice to patients with this disease. Psychological approaches to schizophrenia have a long history. During the 1940s, a number of psychological theories of schizophrenia came to the forefront of American psychiatry. 2 major influences were psychiatrists Frieda Fromm-Reichmann and Harry Stack Sullivan. As I mentioned earlier, the first antipsychotic drug, chlorpromazine, was discovered serendipitously as a schizophrenia treatment in 1952. However, during that time, American psychiatry was very much dominated by psychoanalysis, by Freudian psychoanalysis, and the reception to chlorpromazine was quite muted. Over the ensuing decade, however, neuroleptic medication became the standard of care. Later theorists from a psychological perspective included Silvano Arietti and Harold Searles. Here's a picture of Arietti on the right. He was an Italian-American psychiatrist born in Italy and immigrated to the US. It's funny, Arietti is really my main sort of theoretical inspiration and mentor. I was doing my training at the University of Pittsburgh, and I was just walking through the library. There was a separate psychiatry collection of the library, and I was seeing books, written by Freud and Winnicott and Sullivan and the like. And then I came across a book titled Interpretation of Schizophrenia by a guy named Silvano Arietti. I had never heard of Arietti before. And I said, geez, this guy's name is Italian like mine. And I picked it up. And that was basically the start of my interest in schizophrenia, and ended up doing some work there at Western Psychiatric Hospital in Pittsburgh. And I continue to write about Arietti's ideas and have published a bit on his work. But here's a quote from Arietti describing the need for an integrated, pluralistic, or biopsychosocial approach to schizophrenia. He's writing here in 1978. I believe that whenever possible, an attempt should be made to integrate the biological with the psychological. Although I am convinced that every function or dysfunction of the brain is mediated by a biochemical change, I have always found myself drawn more toward inquiries into the psychological factors which bring about suffering or dysfunction, or are powerful enough to change what is only a biological predisposition into a clinical actualization. And I share this quote because it is sort of a reflection of my own beliefs about the need for a biopsychosocial approach to schizophrenia. As I mentioned earlier, much of the treatment for schizophrenia nowadays consists of a pharmacological approach. Medication for schizophrenia is very helpful for many patients who suffer from the disease. But what medication cannot do is provide some meaning to the patient, help the patient navigate life situations, bring about relief of the negative symptoms of the disorder. So when we talk about schizophrenia, it's a disease that's comprised both of positive symptoms and negative symptoms. We think mostly about the positive symptoms. Positive symptoms are, they're termed positive symptoms because they are added on to normal human experience. So hallucinations, which are sensory misperceptions. You can have a hallucination of any of the five senses. And delusions, which are fixed false beliefs. So those are the positive symptoms of schizophrenia. The positive symptoms are very effectively treated with antipsychotic medication. Sometimes the response is incomplete, but the positive symptoms are treatable with neuroleptics. The negative symptoms, which we don't talk much about, are really not affected very much by neuroleptic medicine. And these include a flattening of the affect, or basically a dulling of the expression of emotion, problems with socialization with others, so problems in the interpersonal sphere, and other symptoms that are removed from everyday or normal human experience. We call these the negative symptoms. And I think that this is where psychotherapy is very possibly the treatment which brings about the most change in the patient. So there may be no single psychodynamic psychotherapy of schizophrenia, but perhaps dozens or even hundreds when you look at all the theorists that have written throughout the years. But some common features of a psychodynamic approach include a focus on the early environment of the patient, in particular the causative role of anxiety in the development of psychosis, the meaning and symbolism of psychotic symptoms. So someone practicing from a biological perspective may simply ascribe the patient's experiences as being the result or the consequence of some biological abnormality, that the symptoms are more or less the product of some abnormality in the neurochemistry, for instance, dopamine, which we know is implicated in schizophrenic disease. But a psychological approach sees the symptoms as possessing some meaning, to be unmasked or uncovered during the process of therapy. And I'll give some examples of that. The psychodynamic approach also emphasizes the relationship between the therapist and the patient, including what we call transference and countertransference. and the etiological role of psychological factors, as opposed to the view that psychological dysfunction is merely caused by the disorder. And psychodynamically, we also look at a longer term approach to psychotherapy. In recent years, there has been evidence for environmental influence in the etiology of schizophrenia. And recent research has confirmed the importance of early attachment in the later development of psychotic disorder, the meaning of psychotic symptoms and their relationship to adverse environmental experiences, and the relationship between biology and psychology in individual susceptibility to schizophrenia. So there is some research to support the idea of an environmental influence in the onset of schizophrenic disease. Psychodynamically, we see psychosis as a defense mechanism, as a defense of last resort. So in some, we see defense against an overwhelming and unbearable self-image. Rather than accept these critical and hostile ideas towards the self, the patient projects them onto the outside world. They are after me. They are criticizing me and telling me that I am no good. And thus, psychosis develops to rectify an untenable inner anxiety, and a very delicate psychological equilibrium develops. We see symptoms as a problem and a solution to a different problem. And this is what Freud called a compromise formation. Some compromise develops within the patient's psyche. And this may explain non-adherence to medication and the like. So we see psychosis as developing for some reason as a defense against an intense and unbearable anxiety, usually having its roots in a fractured self-esteem or ego. We also see symptoms through the lens of concretization and metaphor. That psychotic symptoms like hallucinations and delusions reflect psychological processes known as concretization, which is the transformation of abstract beliefs or ideas or wishes into concrete representations of forms. And I'll give you some examples of this. In paranoia, the patient, this is Arietti writing, projects to the external world the evaluation of self that he previously accepted. No longer will he accuse himself. The accusation now comes from the external world. Arietti saw catatonia as a disorder of will. Catatonia is a syndrome often seen in schizophrenia, but also seen in other psychiatric disorders, which involves the patient assuming a statuesque position for long periods of time. The patient may seem as though he or she is frozen in time. And it can be interpreted psychodynamically as a relief, a defense against the potentially disastrous consequences of responsibility. And the psychoanalytic investigation may reveal this as a defense for the patient. Other examples of psychoanalytic interpretation in schizophrenia. A patient who experiences olfactory hallucinations, that's an hallucination involving the smell of something that is not present in external reality. So a patient who experiences olfactory hallucinations of an odor emanating from his body may have concretized his unconscious belief that he is a foul or rotten person. As unpleasant as it is to smell awful, it's much more tolerable than to believe that one is awful. That's a psychodynamic interpretation of olfactory hallucinations. And a man who believes others are controlling his thoughts experiences a reactivation and a concretization of the way he once felt that his parents were controlling or trying to direct his life and way of thinking. The take-home point here is that there are ways of looking at psychotic symptoms within the context of schizophrenia, or really any other psychotic disorder, from a psychological perspective that tries to make some sense of the experience. That the experience didn't develop in a vacuum, or the symptom didn't develop in a vacuum. There are often reasons why, psychologically speaking, the patient has developed a particular symptom at a particular point in time. And that's what a psychotherapeutic approach can assist with. So when we talk generally, though, about the psychotherapy of this disease, what are we really looking at? Well, psychotherapy aims to reestablish human relatedness. The schizophrenia patient very often is someone who withdraws from society, withdraws from human relationship because it is overwhelming to the anxiety that is produced by human contact is so great that the patient's response is withdrawal. And this is very often the case in the early stages of psychotherapy, where you have to do a real good job at providing a foundation upon which the patient can develop some basic trust. Psychotherapy also aims to understand the psychodynamic history, to target symptoms with specific techniques, and encourage new patterns of behavior in the world. The establishment, once again, of basic trust with the patient is of paramount importance. Without trust, there is no psychotherapy that can take place. Warmth and closeness and support. In the words of Harry Stack Sullivan, the patient must feel that he is no longer alone in the world. And once anxiety subsides, then interpretations as to the meaning of their symptoms can be offered. Arrietty wrote about a concept known as the listening attitude. I don't really have time to talk about that much, but basically the idea is that the patient experiences some emotional overwhelm and then places themselves unconsciously into this listening attitude, where they come to expect a hallucination to occur. And you can try to help the patient catch themselves before they put themselves in this listening attitude. And many of my patients report that in time, the incidence of psychotic symptoms dissipates and decreases once they realize the connection between their emotional state and the onset of a hallucinatory experience. And in psychotherapy, we emphasize autonomy and individuality and self-assertion. I'd like to end with a quote from Arrietty, written in his 1974 text, The Interpretation of Schizophrenia. And it is probably my favorite quote in all of the history of psychiatry. And it talks a little bit about psychotherapy for these patients. To summarize, with many patients who receive intensive and prolonged psychotherapy, we reach levels of integration and self-fulfillment that are far superior to those prevailing before the patient became psychotic. As I have said elsewhere, this does not mean that all of the troubles of the patient will be over, even after successful psychotherapy. We must repeat once again the famous words of Frieda Fromm-Reichmann that we cannot promise a rose garden. It would be utopian to believe that the promise of life is a life comparable to a rose garden. Utopian for the patient and utopian for us who want to be his peers. But I think it is not utopian to promise to the patient what we promise to ourselves, his peers, sooner or later in life, to have our own little garden. Well, thanks everyone for listening. I hope that you learned something. And at this point, I guess we're open for questions.
Thank you, Dr. Ruffalo. In fact, we have reached the Q&A portion, and I would like to encourage everyone, if you do have a question, you can get it across one of two ways. You can either go to your chat function and you can type the question to myself, Ryan, I'm the moderator in the chat, or you can unmute yourself once called upon. Down on the bottom, you can raise your hand under where it says down at the bottom of your window, you have a reactions tab. And if you click the reactions tab, you can actually raise your hand and then I will call upon you and you can unmute and ask your question directly. I do know I received a couple of questions during our talk, so the absence of any raised hands, I will go ahead and ask those questions. The first one is for Dr. Plank. How do you see the future of social media continuing to affect plastic surgery and individuals over happiness?
I think people, the younger generation, definitely understands using filters, and I think they have a better grasp of the power of social media. And I think they're more intuitive because they're always getting fire hosed with a lot of information all the time. So if you have a level of noise, I call it noise, you know, that's its background. And that's what the younger generation is getting all the time versus my generation. But then you have signals, things above that noise that people realize what's true and not true, what's false, and what's reality, what's not reality. So I think the younger generation understands that, whereas, you know, the Generation X, like myself, kind of gets tumbled in that dryer of social media, you know, especially in the dating world. But I think social media in the future, you know, you still have the FaceTime, the DMs, all that stuff that's there. I think what's lacking, and I think Dr. Ruffalo will support me in this, is the human interaction. I mean, the evolution of social media has gone so fast, you miss all the nonverbal cues. What is it? Only 7% is what a person says. The rest 93% is nonverbal cues. So I think that's what's lacking, and that could be dangerous for a younger generation.
Thank you, Dr. Plank. It does appear we have a hand raised. Joanna, would you like to unmute and ask your question?
Hello, my name is Joanna. I just wanted to thank you all for speaking, especially as someone that plans to go to medical school soon. It was really neat to hear all about what's going on. I think in terms of if we look at medicine as a whole, of course, there's a lot of room for growth and improvement, but I would argue that specialties like plastic surgery and psychiatry are more prone to this sort of growth and evolution. So I was wondering if you, either Dr. Plank or Dr. Ruffalo, if you would agree that those fields are more vulnerable to change than other fields of medicine, or if you would argue that there's more of a standard sort of ground there that the field is built upon.
Yeah, I cannot speak to plastic surgery. Frankly, I know nothing about it, but I can speak a little bit about psychiatry and psychology. And, I think with social media, what we've seen is really a greater understanding in the general public of the prevalence of mental disorder. I think awareness campaigns, they are a double-edged sword in some ways. I think, and a lot of what is discussed on social media tends to be, I think, contribute to over-pathologization of mental disorders in society, where we begin calling what used to be called, sadness, depression, mild depression. I think this is becoming somewhat problematic. So social media, it's sort of a double-edged sword, I think, when it comes to my field, in the sense that it can raise some awareness for the severely ill and patients who have bona fide psychiatric illness. I think it's a wonderful thing. And thus, I think the American Psychiatric Association and other mental health organizations really are trying quite hard to figure out how best to use social media to help people in need.
Okay, it looks like Dr. German, you have your hand raised as well, if you want to unmute.
Thank you, Ryan. Well, I have a different question for each of you. Dr. Plank, two questions. Do you see a lot of people who become addicted to plastic surgery? And that probably combines the professions of both of you when we see people like that. And then the other question for you is, what % of your patients are you really fully able to meet their expectations? In other words, how big of a problem is that for a plastic surgeon?
To answer your first question, I don't see a whole lot of people addicted to plastic surgery. With the psychiatric disorders, we are trained in that very well. We call that body dysmorphia. So those are the people that have exuberant concern about a body part that just is standard deviations away from the normal. And we are definitely tested about that. And it also comes down to ethics. So if you have somebody that's seen multiple doctors, we see a lot of patients that go to Miami, get multiple procedures down in Miami. They'll come back to me for certain issues, and it's up to me as a plastic surgeon and a physician in general to have medical ethics to deny patients that are seeking too many plastic surgery cases. Expectations is also an issue, which leads to your next question. Most people do okay, surprisingly well. I know I talked about social media with the filters, but it's not as a big problem as it really is. Once I show them what's possible, what's doable using the vector imaging, show them in the mirror. But I think the people that do seek out plastic surgery, I would say about 80% are okay, with passing my itinerary and criteria for passing what I think is an appropriate level of plastic surgery. I kind of describe myself as a surgical psychiatrist sometimes. you know, and it's up to me. And I also read the journal articles within plastic surgery. It does have a psychological component to it. So you have to look out for the patient. You're the most responsible for the patient, and protecting the patient from themselves sometimes too.
Well, given that you teach our students, I'm really glad to hear that. And Dr. Ruffalo, it seems to me that for the last 50 years, medicine has been fixated on oral therapy for everything. And what I mean by that is really drugs. It seems that there are two ways to make someone better. You either give them something, a drug, or you cut them. And a lot of our ills, I think, are caused by habits that we form that are unhealthy habits. And we're now just becoming aware of that. So someone who does what you do is becoming more and more important in keeping us healthy. I wonder how you see the profession shifting from a focus on surgery and pharmacotherapy to the kind of work that you do, which I think is very important. And actually, if you can do your work and make someone better, our mantra in medicine, primum non nocere, which means first do no harm, is really epitomized by the kind of work that you do. So I'm just curious about how optimistic you are about us as a profession heading in that direction.
It's a wonderful question. Thanks, Dr. German. I get this question a lot, actually, and very often from psychiatry residents. I think there have been great shifts over time in the history of psychiatry, from psychogenic theories of mental disorder to biological theories and back again. I think that Dr. Klapik, who is the founding chair of the psychiatry residency program, really reflects a really integrated biopsychosocial approach to mental illness. Dr. Klapik, for those who don't know, is trained as a psychoanalyst, like I am, and also started the electroconvulsive therapy program at the Menninger Clinic. So he's wonderful at integrating both biological and psychological theories and models to the treatment of patients in need. I think that psychiatry, for the past, starting in the 1980s with the development of the SSRI drugs and continuing into the 90s and the 2000s, really became very heavily dominated by the biological approach. The residents coming in nowadays, many of them, in fact, most of them, have great interest in psychotherapy. I think that there's an understanding that biology is, of course, of immense importance in how we conceptualize mental disorders, but there are other lenses through which we can see patients. And I think that most patients are helped by a combination of the psychological and the biological approach. And actually, when you look at the research literature, most patients show best improvement when they're in both psychotherapy and they're receiving medication treatment. So I think the field is actually heading in the direction of a greater pluralism. And that actually makes me very excited.
Good to hear.
Yes.
Dr. Ruffalo, we do have a couple more questions for you. The first one here, it really focuses on patients who come to you or are sent to you, but are really unwilling, or maybe they're not aware of the kind of treatment that they really need. And what are your biggest challenges with those types of patients who you interact with, but may not be necessarily willing or open to admitting that they need the treatment?
When I was in my training at the University of Pittsburgh, a psychiatrist whom I trained under, he said, do yourself a favor, Mark. I want you to I want you to put on the sports network before you come to the hospital in the morning. I want you to know if the Pirates won or the Penguins won last night, because this is perhaps the only way that you will make any meaningful connection with the patients on this unit. So the best approach, it may not be answering the question directly, but the best approach is to find something neutral to talk about, some common subject upon which you can both share some interest, and this is your way of very slowly over time getting the patient to trust you, getting the patient to relate to you. And 50% of schizophrenia patients really lack any insight into the fact that they're ill. Bipolar patients also suffer with this to a lesser degree. So the work is not always easy, but there are ways to navigate this, and it takes patience and time, and a willingness to just sit and listen to the patient without offering any advice or dictating to them how they should lead their lives. So it's a great question, and thank you for it.
And almost a follow-up to that, but not directly, are extreme therapies still used, Dr. Ruffalo, such as, say, shock therapy? If so, what are your thoughts on these practices?
Well, electroconvulsive therapy, which used to be known as electroshock therapy, I wouldn't categorize it as an extreme therapy. It's in fact the single most effective treatment in all of psychiatry. For treatment-resistant depression, it's effective roughly 90% of the time. It's the single most effective treatment for catatonia, in addition to benzodiazepine drugs, and for some other conditions. ECT is widely used. About 100,000 people in America receive ECT annually. For some patients, it's the only thing that helps them. We see very negative portrayals in the media and in film about ECT that are wildly exaggerated and largely depict a very outdated and outmoded type of electroconvulsive therapy, which is not practiced anymore today. ECT is done under general anesthesia with an anesthesiologist in the room, a psychiatrist who administers the treatment, and with a success rate of 90% or higher. It is one of the most effective treatments in all of psychiatry, if not all of medicine.
Excellent. That sounded pretty definitive to me. So I do not have any more questions in the queue. Does anybody else have any questions from the audience? Any raised hands? I don't see any. And so with that, I will go ahead and close out the Q&A portion. Thank you so much, Dr. Ruffalo and Dr. Plank.
Thank you so much. I really appreciate everything you do for the College of Medicine. Thank you.
Thank you as well.
Thank you. Thanks for having me.
We are grateful. So let's have a round of applause for Dr. Plank and Dr. Ruffalo. Thank you so much for sharing your insights with us, and what a fascinating talk today. We really greatly enjoyed the information that you shared with us. And thank you to all of our guests that are on the call and our friends for joining us tonight. We look forward to seeing you at future events to share information on our programs at the College of Medicine in education, research, and patient care. And we also want to thank Ryan Rutherford behind the scenes for being our moderator this evening and our question and answer portion. And we also would like to thank Mike.
Oh, Carly, you muted yourself.
Sorry about that.
that would be Michael Pugh.
Michael Pugh, who is our Zoom extraordinaire. We do all things with Michael, so thank you so much for all that you do. And
pleasure.
Following the event, you will receive an email with more information about the UCF College of Medicine and ways that you could become more involved with the college. And you will also receive a link to a survey so that you could provide feedback to us, which is a very big gift for us for future MEDTalk events. So thank you all so very much. We're very grateful to all of you for your support, and thank you for joining us this evening. And Dr. Ruffalo and Dr. Plank, thank you so much for your knowledge and for your insights and for your wisdom.
Good night, everyone.
Good
Thank
night.
you, everybody.
Thank you.
Have a good night.